Welcome everyone to this Evenings with Genetics tonight on the topic of precision medicine and heart disease. I am Susan Fernbach, the director of this series, and this is sponsored by the Department of Molecular and Human Genetics at Baylor College of Medicine and Texas Children's Hospital. For interpretation to Spanish, please click on the language button, the interpretation button below. And simultaneous interpretation is possible thanks to Mercedes Alejandro. Please write your questions in the Q&A box, and that button is also at the bottom of your screen, and we'll answer questions at the end of the program. Dan Riconda, the director of the Baylor College of Medicine Genetic Counseling Program, will be moderating the Q&A. So thank you, Dan and Mercedes. The music we've just heard is by members of the Lyric Ensemble of Houston, and they are musician scientists who have played for many years for us during the in-person seminars. So they reached out and wanted to provide a tape for us for today, and I'm greatly appreciative of them. So hopefully we will have our in-person seminars back at some point in the future and see them in person. And now I really have the distinct pleasure of introducing Dr. Christie Ballantyne. He is an internationally renowned expert on lipids, atherosclerosis, and heart disease prevention. His research interest in the prevention of heart disease has led him to become an established investigator for the American Heart Association and to receive continuous funding from the National Institutes of Health since 1988. Dr. Ballantyne now has over 800 publications in scientific journals in the area of atherosclerosis, lipids, and inflammation. In 2012, he received the American College of Cardiology Distinguished Scientist Award. In 2014 and 2015, the Thomas Reuters recognized him as one of the world's most influential scientific minds. Clarivate Analytics Web of Science named Dr. Ballantyne as a highly cited researcher in the top 1% of researchers most cited. Dr. Ballantyne was awarded the Baylor College of Medicine Michael E. DeBakey Excellence in Research Award, and his research in biomarkers has led to the FDA approval of 2 biomarkers for risk prevention of cardiovascular disease. And he has played a prominent role in the development and FDA approval of new therapies for treatment of lipids. Dr. Ballantyne is the Chief of Cardiology and the Chief of Cardiovascular Research at Baylor College of Medicine. He is currently the Director for Cardiometabolic Disease Prevention at Baylor College of Medicine. So from your homes, please give Dr. Ballantyne a warm welcome.
All right, thank you, Susan. It's nice to be here tonight and have a chance to, let's see if we can get these slides up now. All right, so I'm going to talk a bit about heart disease, precision medicine, with a focus on genetic testing. What's the role of that in terms of helping us to prevent cardiovascular disease? And I'll do this from a personal perspective, and we'll talk about how I got started, risk assessment and genetic testing in the clinic. Now, Susan had asked me to have one of my patients in this, but instead I'm going to start off with something more personal. This is my family. And now on the right is my father. When I was a junior in high school, he had a heart attack. He was lucky. He had an episode of sudden cardiac death where he was resuscitated while he was in the hospital, but and ended up living longer. He was 51 years of age at that time. I never knew my grandfather, who was on the left here, because he died of a stroke before I was born. But the person who died at the youngest age was actually my aunt in the middle. And we tend not to recognize that women can have heart disease, particularly if there's a genetic basis to it, which clearly there is in my family. She lived on a ranch, and the first day she had symptoms was the last day of her life. So it's important that we not wait until you have symptoms, because that may be too late. And it's actually somewhat more true for women than men in terms of sudden death. Now, this is my mother's family with it. My mom's on the right, and those are her three brothers. So the question, what genes did I inherit from my mother's side of the family? I think you can see one of them by my hair pattern here. So all of her brothers were bald before they were 40 years of age, and so was I with it. But if we look at the family, that this is the family tree, my mother was the only one who didn't have diabetes in her family. She had a brother with a stroke. My grandmother, her mother died of a stroke at a young age. And on the left is my father, his brother, his sister. They all had heart disease. And unfortunately, my oldest brother died of a heart attack at age 68. So when you see something that runs in your family like this, you have to be thinking is, well, there's probably a genetic basis to this. None of these people were smokers in it. And there's a genetic basis to diabetes. There's a genetic basis to many diseases. Now with heart disease, it's a little bit tricky. Now, sometimes understanding, because it's what we would call, there's many different genes. So prevention has it's so remarkable since I started. Cardiovascular disease remains the leading cause of pain, suffering, and death in the United States. It's heart disease and cancer. When I was an intern, when people had heart attacks, we really didn't do much. We tried to relieve the pain. We would give them morphine and nitroglycerin. We gave them oxygen, and we watched them. We said, stay in the bed, rest. Use the bedside commode. We didn't do much other than treat complications, because we didn't understand the disease process very well. And now we can do a lot of things, but if you think that was bad, look at what prevention was. A high cholesterol was over 300. The only drugs that we had were niacin and bile acid binding resins. So niacin causes a lot of flushing. The bile acid binding resins cause tremendous constipation. So people are either flushed or constipated all day long. Hardly anyone took the medications, and they were very rarely prescribed. In terms of blood pressure, we said your age plus 100 was high blood pressure. So if you were 75 years old, as long as your blood pressure was under 175, we said that was just aging. Now, we don't believe that at all anymore. And then diabetes, the medicines, all we had was insulin and sulfonylureas. They were hard to treat our patients, and we were pretty happy if the glucose was under 300 and someone didn't have symptoms from having such high sugars. So the prevention was terrible. Now, where we stand now, that this needs to be updated 2021. We really have much better medicines for both blood pressure and for treating lipids. And we have a simple concept: is the intensity of the therapy should be related to the risk of the patient. And that concept has been around for a long time. The question is, how do we determine the risk of the individual? And what we usually have been talking about is traditional risk factors, and there's new ways of doing this now, and there's equations, and there's some imaging tests where you can do an x-ray and look at calcium in the heart. So these are all new approaches with it, but it's very important. Is the first step is, what is your risk? And for those of you who are listening tonight, that would be the first question you should have: is the two most likely reasons that you will die will be heart disease or cancer. What is your risk for cancer? What is your risk for heart disease? Now, the good thing about heart disease is we know how to reduce the risk very well. I think if we would start early in life, we would be reducing over 80% of all heart attacks and strokes. We don't know as well, except for a few things like cigarettes. In terms of cancer, there's many things that we don't understand that. So it's important to know your risk, and then you come up with a plan with your healthcare provider, and what's the best approach with diet, with exercise. Do you need medications? And this involves what we would call joint decision making. And why is it joint decision making? Well, when it comes to prevention, you're not having actual symptoms from high cholesterol or high blood pressure. So you really have to buy into the whole program. And as I point out to my patients, it's your heart and your heart attack that you would have. It's not mine. I can give you a roadmap, but it's like this is your car. And if you're heading the wrong direction, you can change directions and you can avoid having a wreck and having damage. But ultimately, you're the driver, and I can help guide you, but you're the driver. So we have to have an agreement on the plan for something to be successful. Well, how do we determine who's at risk? So we have, we can have age is a very important risk factor. As you get older, your risk goes up. Cigarette smoking is very important. Men get disease earlier in life than women. So sugar diabetes is very important. Blood pressure is very important. And we'll talk more about cholesterol here. So you can get blood tests to look at some things. There's some newer things related to inflammation. There's imaging tests, and there are also genetic tests. And this is what we'll focus on some tonight, is about some of the genetic tests. Some of them, there's different things that we can look at in terms of genetic tests. Some of these are pretty rare disorders. Others are more common. And there's actually the development now of genetic risk scores that I'll talk about. All right, so one of the classic things that we have learned about is something called familial hypercholesterolemia. And this is a nice kind of way of remembering this. So the abbreviation for this is FH. So F, family history. H, high LDL cholesterol. What do we mean by that? Well, if it's over 190 for an adult, you should be thinking that's probably hereditary. Over 160 in children. There's a family history of high cholesterol or premature heart attacks and strokes. This is something you should be concerned about, and it's important to get your cholesterol checked. This disorder is not rare. Why are my slides not advancing here? So it's not a rare disorder. It's pretty common. 1 out of every 250 people will have this due to a mutation in one of the genes that plays a critical role for controlling the levels of LDL in your bloodstream. Now, typically you'll see very high LDL. You may be getting heart attacks in 30s and 40s, 50s. And most people who have one genetic mutation, we call that heterozygous, they will respond to commonly used drug therapy. Now, what's less common is if you inherit a bad gene from each of your parents. So you'd have 2 defective genes. And now we see very, very high levels of LDL. They're in the range 400, 500, 600, 700. And you can have heart attacks in childhood. They're much more difficult to treat. This is less common. It's 1 in 300,000 people. It's very severe. It's very important to recognize it early on so that you can treat this. So as I mentioned, there are some genes that play an important role for removing the cholesterol and triglycerides are fats. And if you put fat with water, it doesn't mix. So you have to transport these in your bloodstream in little balls of, we would call these lipids with protein. Those are called lipoproteins. So it turns out there's the bad cholesterol is carried in an LDL particle. It's a low density lipoprotein particle, but there's a gene called the LDL receptor, and there's a protein it binds to called ApoB, and there's some other proteins here. So there's 4 major genes. And what happens is, for example, if you were to get genetic testing, typically they will sequence those 4 genes to see if there is a change in the genetic information, which leads to what we would call a pathogenic variant. So basically a variant where the product of the gene, the protein, doesn't work normally, and then you have poor function or pathology leading to a high level of LDL cholesterol. So as I said, this is not a rare disorder. It's not super common. but it's 1 in 250 people. And it's something that one of the problems that comes up is the lack of awareness of this. It's estimated that out of the people who have this, so in the United States, there's well over 1 million people who have this, only about 20% are diagnosed. And we're part of something called the FH Registry, Cascade FH Registry. And one of the things that Dan may talk about or answer that if you have a genetic disorder, it's very important to do cascade screening to identify all the family members, because there's a 50% chance that your children or your brother or your sister would also carry this gene and have the same risk. So you can diagnose this at age 2 in blood measurements. It's recommended that children age 9 to 11 should all have, anyone with a family history should have this. And it's also that you start the statin therapies early on. Now, in the registry that we did, it turns out the average age of statin therapy being initiated was age 44. And people weren't told that the diagnosis of familial hypercholesterolemia is at age 48. So this is a problem because the cholesterol builds up over decades, and many people are told of this after they've had a heart problem. They've had a heart attack or they've had a stroke. If we could start at age 10, we would prevent probably 98% of these problems. So early diagnosis is critical. And that's one of the things that comes up with genetic testing is you can make earlier diagnosis in life. And we'll come back to the importance of that. So if we look at premature heart attacks, it may be about 1 out of 5 heart attacks under the age of 50 is caused by this disorder. So the goal of treatment is obviously we want to reduce the risk of heart attacks, bypass surgery, stent, stroke, all the things, early death. And we can do that if we diagnose this early and we initiate treatment with medications. Now also we want to work on diet and exercise. And some things that are extremely important is, if you know early on in life, is that it's very important that children don't smoke. And I've seen parents quit smoking so that their children would not smoke. That was the motivation for the parent who had this disorder to smoke, so their child wouldn't have the same kind of a problem. Because if you have a genetic disorder, and this is the things that I always tell my patients in terms of with heart disease. If anyone follows baseball, as you know, we have a great baseball player for the Astros named Jose Altuve. If we look at genetic traits, height is one of the most powerful genetic traits. And so when he tried out for the Astros in Venezuela, they sent him home. They said, listen, you're too short. You will never be able to play baseball in the major leagues. And he came back the next day. Someone called him up, said, listen, you got to watch this guy play. He can really play. And he became the most valuable player in the major leagues and led the Astros to a world championship. Now, what people understand in sports is that if you're short, you do have to try harder. You got to play smarter. And, he can steal bases, he can hit, he can field. He does every aspect of the game well. But we understand life is not fair. People are short, they're tall. Some people have genetic disorders. But that means you just play it smarter. And unfortunately, with a good, healthy lifestyle and with the medications, you can avoid these problems. So it's instead of saying, well, there's nothing, woe is me, I was born with this. So that means, you just have to play it smarter and get the right help. And we have this at Baylor to be able to help you and other family members. Now, this is one cause of premature heart attack. Now, it turns out there's lots of different genes that can predispose to heart disease. And so there has been the development of a kind of a new technology of looking at a large number of genetic variants and coming up with what we call a polygenic risk score. Looking at many different genes, can you identify individuals who are higher risk? So as mentioned, if someone had a problem with the LDL receptor, if we look at 100 people with myocardial infarction, depending upon their age, this was a little bit older than 50, but you're going to end up with perhaps a couple of people who had familial hypercholesterolemia. If you looked at this was developing a polygenic risk score, and they looked in two populations. One was a study of premature MIs, one was a large epidemiological study. They found that you could look at individuals who were in the upper decile, but that you would find, in fact, a large number of individuals, 17 of the ones who had premature heart attack had a high polygenic risk score. So this would be another way of doing genetic testing to find people who are at increased risk earlier in life. And it's something new, and that still needs some work because most of this was developed in people, these polygenic risk scores, who were of European ancestry. And it turns out the genetic variants differ sometimes by different, basically, inheritance. So if somebody's East Asian or South Asian or African American, the same polygenic risk scores may not work as well. It's an area that's undergoing a lot of research right now. There is another factor that it's important to know about that's hereditary. We talked about LDL cholesterol. There's another one of these lipoprotein particles that looks like LDL, but it has another protein hooked to it called apo(a), and we call this lipoprotein (a). This is another genetic risk factor, and about 1 in 5 people have a high level of lipoprotein (a), and if you have FH, it's even more than this. It's about 1 in 3. So this is unfortunately not measured by most primary care physicians, so most people don't know about this. It does promote heart attacks and strokes, and also some problems with the aortic valve. We think it promotes atherosclerosis and thrombosis, and it is something, these are the levels. Unfortunately, they have 2 different types of measurements. One's in milligrams, one's in nanomoles, but a normal would be less than 30, and a high would be over 50 milligrams or 125 nanomoles. So it's something, if you have a family history, get your lipids checked, but you may also want to get the lipoprotein (a) level checked. This has a pattern that we would say is autosomal dominant. What does that mean? It's in each generation. It can be here, we see it was in the grandmother, and then this was, if we go down, starting here and going upwards, but it's in each generation. And it's a 50% chance that if you have it, your children or your siblings will have it. All right, so genetic testing, this is something where there has some aspects, I've talked about this with some of my colleagues. They said, well, we could do we really need genetic testing or not? We can wait till people have it later in life. We could be doing calcium scores to see if they have plaque in their heart. And we don't have enough information on it. So one of the things that we are cognizant of is that, in addition to people going to see healthcare providers, there's also people who are going to the internet and, in fact, just wanting to get health information. And this is some issue that right now, as you're aware, there's lots of companies that are giving direct-to-consumer genetic testing. This has been going on, and in fact, it's taking off like a rocket. You can see the tremendous increase in that. So we feel that it's very important that if we're going to start getting genetic testing, particularly it's approved for risk prediction, that in fact the biomedical community in places like Baylor College of Medicine, we like to be involved with moving this field forward, so that when you get a genetic test, at least you're getting something that's useful. And I mean, I think some of the things are interesting is, what's your ancestry, and do you have any Neanderthal or things like that? I mean, it's good conversation, but in terms of risk prediction, some of the information that you're getting may be not the most valid or useful. So we want to be in the middle of this. This is, the answer to the people who say, well, we're not ready to do this. Probably the same thing as the one had a wheel. We don't need the wheel. It's what's the point of that? So here's the problem with prevention. I'm, like it's mentioned, I'm chief of cardiology. And in cardiology, there's all kinds of dramatic things that people do when you have a heart attack. You get an acute angioplasty. We do heart transplants, put people on lip assist devices. So there's all kinds of dramatic work that's done when people are extremely ill. And that's very important. It'd be like if your house is burning on fire, you want a fireman to come rescue you. The problem that comes up, so that's the scene on the left. But unfortunately, the fires are frequently, everything's burning up. If you think about what saves more lives, firemen or having a plan where you put in smoke alarms and you have a well-designed house and you have things that are safe so you don't start the fire in the first place, that saves far more lives than firemen. Now, you still need firemen, but we also need to make sure we don't have fires done by carelessness or letting things be in. And so on the right, this is preventive cardiology, pretty boring to a certain extent, but it's far more effective. If your house is burning down and someone rescues you and their house burns to the ground, it's wonderful that you got rescued, but you lost your house, and usually a lot of damage is done and tremendous expenditures. And if you could avoid a heart attack or stroke in the first place, it makes a lot more sense. We do too little, too late. And this is where genetics comes in. Genetics tells us about predisposition early in life. And so if you were to screen for familial hypercholesterolemia, it turns out that you can do screening for LPA, measuring it, but there's also genetic variants that, since it's a genetic factor, these polygenic risk scores. And so ideally, we would begin prevention in childhood with healthy diet, exercise, and the entire family would try to improve their lifestyles. And one could start medications that are very inexpensive for statins and blood pressure early in life for the people who are not succeeding well with this. So that's the concept. Now, we've done a recent project at Baylor with the Genome Center, which was called Heart Care, where we are trying to implement this in clinical practice. So that a lot of times people have done studies where it's all anonymous, they collect DNA and they do DNA studies. This was one where actually there was 158 genes sequenced, the ones for lipids, but other ones, a polygenic risk score. I mentioned lipoprotein A, the variants in there, pharmacogenomics, and this information went back to the doctor and patient in the medical record. So there's genetic aspects that lead to arrhythmias and cardiomyopathies, weak heart, and problems with the aorta and the vessels, along with the lipids I talked about, and some other cardiovascular related problems. So these were all sequenced, these genes, and they only reported pathogenic variants. Now, and to make sure that when there was an abnormality that was clearly of importance, that got reported to the physician, then also to the patient. And the report was done in a way that we tried to make it easy to understand, because remember, this went to our cardiologists who are not geneticists, and they would say if there's a positive report, and they would give a recommendation, and they would talk about if you have a polygenic risk score, what would you end up doing? But that's usually going to be diet and exercise and could be a statin. So there was trying to give clear information to that, and it went back into the medical records. So we have an electronic medical record, and it turns out some of these things are not quite as simple as you want, and patients can respond through my chart about this. We have, as you know, in Houston, our demographics are we're, I think, the most diverse city in the country, but this study was about half men and half women. And we ended up having about similar to Houston, about a little bit less. I guess in Houston, we'd have probably 60% non-white, but we have about 60% white in the study, 14% Hispanic, Asian, others in the study. And it was people in general cardiology, but also heart failure, electrophysiology, and our surgeons who do a lot of aortic disease. So it turns out about a third of people had something we would consider to be worth commenting on. Like, did they have a pathogenic variant? That was 9%. Did they have a the LPA variant, which might be with that high LPA. We mentioned that 20% of people, and they have a polygenic risk score. And this information ended up being useful to our physicians. It felt that most of the time it was helpful in terms of the management implications. There were a large number of genes, which many were surprising that we didn't, that physicians had no idea that their patients had these problems with it. So there was a lot of new information that came up about it. And there was also some information about potentially, do you have a problem with your metabolism of simvastatin, which is a cholesterol medicine, or a blood thinner called warfarin. So when we ask the physicians afterwards, did they feel this was beneficial, is that most of the physicians felt that yes, they strongly agreed with it, and that medical management changes were done in the majority of patients with basically on this information. So 32% positive rate, 9% what we would call as high impact Mendelian mutations and key risk genes, and there was intervention. So it's a proof of concept that we think this could be beneficial. And there's more research ongoing, and the project will now be going to doing something in South Texas in a different healthcare setting and see if we can reproduce the results. Well, I'm going to stop here and summarize what we covered. Cardiovascular disease is the most common cause of death, morbidity, so also morbidity in the United States, has a very strong genetic component. Genetic diagnosis for familial LDL cholesterol disorders, we mentioned familial hypercholesterolemia, and also high levels of lipoprotein A, that may improve if for example, if the individual is identified. This is why we have genetic counseling. Then there are the expertise of basically what do you do with that information, and helping what we call a cascade screening, identify other family members who may have the same condition and also benefit from earlier initiation of therapy. Now, we also think that this could be done in a more comprehensive manner. And there's this, Susan remembers I did a postdoc with Art Baudet in genetics many years ago, and we'd spend doing a sequencing challenge, and we could take all day to sequence a few hundred bases. Well, now you get your entire whole genome sequenced, and so there's the ability that this could be done with a reduction in price in a more comprehensive way, to look at as like that project, getting a lot of genetic information that could be more easily available to patients. There is some research that's needed for these polygenic risk scores to make sure that the information is accurate and useful in different racial and ethnic backgrounds. We saw some of this in our experience here. But I think genetic testing may help us to solve this problem of doing too little, too late. Knowing early in life that someone has a problem, and then you can lead your life in a way that's smarter, healthier, and then starting medications earlier so you don't end up with all the consequences of that genetic predisposition. And I will stop there, Susan. We'll open it up for questions from the audience. Let me stop sharing.
Fantastic. Oh, this would be great. And Dan, are you seeing any questions yet in the Q&A? That was wonderful, Dr. Ballantyne. Thank you very much.
Not as of yet.
Okay. Well, I have a question. I was just going to ask you, had the slide about testing children for hypercholesterolemia. And so is the goal that then children would be tested in universal screening early in life, or through?
So, yeah, Susan, they've recommended this, even the UK, which tends to be, and they have a healthcare system where they're very cautious on, what they spend money on. And they feel that it would be cost effective to do widespread screening, basically universal screening, to identify familial hypercholesterolemia. Because if you start early in life, you can really prevent all the, the morbidity from this if you were to get people's cholesterol lowered earlier in life. my thought is if you're going to do that, you could expand it. And I think you could identify the LPA most likely, and then maybe some of these other things too. But I do think there's this opportunity to dramatically improve the field of prevention. You know, these polygenic risk scores might be also useful, because it also happens that so 1 in 250 people have basically the mutation in the LDL receptor with these other genes. But it turns out there's another few percent, maybe 5% of people who have actually a bad polygenic risk score from maybe a mixture of genes from their parents, and they end up with a very high LDL. Well, that's also familial. It may not be a single gene, but it's still from your family. And knowing about that may also be useful in terms of, I think, you know, getting an earlier start on doing something about it.
Great, wonderful. And are there any other questions coming through? Because I do have another question too.
None on the screen quite yet.
Okay. The study that you mentioned, is that still recruiting, the study at Baylor through the Human Genome Sequencing Center?
So that study is not recruiting anymore. You know, it got stopped a little earlier because of COVID. We were going to do 1,000 individuals, but and it is one of the goals in that is also to be able to when one of the things that if you're going to do this, it's really important that you have this would, you know, Daniel's helping us with this in terms of the genetic counselors available, because what a lot of times will end up happening is that the physicians, sometimes you do identify genes which are, you know, there's just, you need to have the ability to refer to a geneticist. And then other times you may just simply need is something even that perhaps is pretty well known, like the LDL receptor mutations. Then people sometimes would like to see a genetic counselor because there's a question of, okay, you know, childbearing, and there's a lot of questions that come up when you have a genetic disorder, and that genetic counselor could also help with some of the cascade screening. Dan, you want to comment on terms of that part?
Well, I'd be happy to, but I know you probably know the answers to some of these questions. But when it comes to uptake of cascade screening, that has been somewhat difficult to see come to fruition. So I think one of the barriers that has existed with the benefits of identifying individuals is whether or not we have the appropriate resources or the necessary resources to facilitate communication, either through our patient who is identified with increased risk or through other family members. And that has been one of the limiting factors, is you can't just contact someone without their permission. Maybe you would want to comment a little bit on some innovative ways that people have attempted or tried to overcome that through electronic or other means.
So, you know, this is one of the challenges that and this is something where unfortunately the EMR, instead of making it easier, made it harder. It used to be, so I could see the parent, they could just give me the name of their kids. I could write their names out on a lab slip. They could take the lab slips over and get tested. Well, now I have to order, if I do, you know, I need to go through the EMR. And if they've never been a patient of mine, I cannot order lab tests on someone I haven't seen very easily. They're not a patient, they're not in the system. There is a way around this. So one of the things that does come up is that this happened just recently, is that now Quest and LabCorp have direct to consumer testing. And so basically you can, and this is something that's important. If you have a high cholesterol, for our audience, if you have something that's hereditary, or the lipoprotein A, your family members, and they need to look online about this, they can go directly to a Quest or a LabCorp. There is direct to consumer testing. They don't have to get a physician order. Make sure that you can check the prices beforehand. The prices are quite reasonable. And there, you know, unfortunately, some labs, like there's another one like Lab Test Anywhere, with it. But I think, unfortunately, and some of this ends up kind of going back to the family members. But you can get your kids tested without having to have a doctor write an order with it. Particularly, a lot of my patients have even grown children that never got tested, so they're adults with it. So this is something where I frequently work through the affected family member to make sure they've informed their children and their siblings and everything else about this, that they should get tested with it. And you can now. It used to be easier. I could just write them all lab slips and they get it done. Unfortunately, now with our electronic medical record, I can't be ordering labs on people who've never been into the system for it. But this is a good thing where the direct-to-consumer testing actually makes it easier to implement some of this.
There is a question in the chat asking if you could provide additional information on the LPA, little a, consequences and degree of risk, if possible.
So LPA is it's a very important risk factor, and I think where we stand on it is that currently we do know if you have for example, if you have a very high level of LPA, it's something that we can kind of add to your other risk factors. We look at the total picture. So it's also going to depend upon what is your LDL cholesterol. Do you have high blood pressure? Do you smoke? Do you have all these other types of problems? But we see people with very high levels and they have premature events. So the approach right now is you control all the other risk factors. You treat their blood pressure more aggressively. You work on diet and exercise more. We also use statin therapy. We know statins help reduce events in people with high LPA. Unfortunately, the statin itself does not lower LPA. So the only drugs that we commonly use that lower lipoprotein A are the PCSK9 inhibitors. And these unfortunately are no generics. They're expensive. They're highly effective. They lower the LPA and they lower LDL, and they've been shown to reduce cardiovascular events in people with high LPA. We are studying, if someone has had a heart attack or a stroke, we are testing new therapies that are basically, we live in the world of messenger RNA therapeutics now. I mean, most of you listening on this call have had an mRNA vaccine. That's where you got an injection and the mRNA produce the protein that you have an immune response to. Well, we're using antisense and small interfering RNAs, and basically the injection, it goes straight to your liver and it degrades the messenger RNA. So you don't make the protein for apolial A, so you never make lipoprotein A. And we're doing trials with these agents. They reduce LPA 80, 90%. It's a long process from doing clinical research on the studies, and we're doing a cardiovascular outcome trial, but the drugs are not currently available except in a research protocol. But it's another example how genetics has identified the target, and may also, with some of the insights from biology of genetics, is also with biotech, helps us develop a treatment for it.
I don't see any other questions right now, but as you think about moving forward, are there any new markers that are being developed that may eventually come to clinical practice?
Yeah, so there's a lot going on in terms of other blood tests with it. So there's protein markers that can tell us if you're having, and turns out there's a risk for heart failure. And there's things that we measure called troponins and NT-proBNP. So there's new blood tests that can identify risk. There's some advanced lipid testing that may be also beneficial. And then, we're doing omics where there's a test where we get 5,000 proteins. And there's, metabolomics where you get hundreds of metabolites. So that's really, I still think they're trying to offer these to clinically, some of it, but I feel like they're really more at the research stage right now. mean, I don't understand how to use them, and we're doing the research, so I'm not sure how clinically people know how to exactly where they fit in, but they're promising technologies. It turns out that one of the reasons genetics has advanced so rapidly is that the sequencing technology has been fantastic. So this is advanced much faster than the ability to measure proteins accurately, and proteins have all these different alternative forms with it, that, you know, glycosylation and post-translational modification. The proteins are just they're a lot messier and harder to get the data on, and it's not as reproducible as the genetic data. This was, I guess, the question was about the medicine released to the general public about LPA. You know, it's going to be years, unfortunately. That's so with heart disease, when we have these new therapies, we have to show not only that they lower the level of lipoprotein A, we have to show that there's an impact on heart attacks and strokes. So it takes very large studies with people followed, thousands of people followed for many years. So it'll be a number of years before they're approved, before they're even submitted to the FDA. We'll have to get the results of the outcomes trials for that.
There's a follow-up question to something you mentioned before. How long before those meds, and I think you might be referring to the mRNAs or the other blockers, if you will, might be released to the general public? And in particular, the follow-up to that was, I meant the vaccine that goes to the liver.
Yeah, and so now there is one that we're working on for another rare disorder with extremely high triglycerides, and that's called familial chylomicronemia syndrome. So that's another one where triglycerides are in the thousands, and it's very difficult to treat. You don't respond to the medications that we have available, and you get pancreatitis, and you have to be extremely restrictive on the foods that you eat. Those trials are ongoing, and I think the approval will be sooner. They also go to the liver, and they do the same concept as, so I think those might be available in a year or two. I'm more confident that all we have to do is show that they're effective for lowering triglycerides and that they're safe. And that's easier to do than showing that they reduce heart attacks. So those will be, I think, we'll have in the not too distant future. And we have, once again, multiple trials for people who, if they have a very severe triglyceride problem, we have several trials that are available in terms of, you know, might be beneficial, and which also have open label long-term extensions, so you know you get the drug.
Thank you. There's a follow-up question on the LPA. If all else is equal, are you able to give a likelihood ratio when someone's LPA is up? And I think you partially answered that, but I guess they were looking for
So, you know, what ends up is you can end up talking about that you might go up about 50%. Now, if it's extreme, it may be 2 to 3-fold. There are people who have levels that are 100. So we talked about 30 being high or 50 milligrams. So there's people that have 150 or 200 milligrams. So there's the top, you know, less than 99 percentile. But for the most part, it's going to go up more in the range of 50%. So you could still there are these risk scores. And so if someone has everything else great, and if you multiply by 50%, it's still pretty low. The part that people miss is that with heart disease, and I used to use the example of Bill Clinton, is that, you know, if someone's, it's the person who sometimes has multiple things that are, so the blood pressure is a little high, they're overweight, they don't eat, their food is not that good, their cholesterol's on the high side, they have a low level of the HDL cholesterol, maybe the sugar is borderline. So they have 4 or 5 things wrong. And what ends up happening, it's all kind of multiplicative. So 2 times 2 times 2 times 2 times 2, you know, 2 to the 5th is 32. Well, you may have a high LPA, one thing that's wrong that's very striking, but everything else is perfect. So even if that's a 4, it's 4 times 1 times 1 times 1 is only 4. So I think a lot of times what we do is we we don't pay attention to that clustering of multiple abnormalities. And so we miss that individual. And now with LPA, it's not even measured. So that's why it's missed also, even if it's strikingly high.
Well, Dr. Ballantyne, thank you very much. This has given us a lot of information, and prevention seems to be the key, and that there are steps that people can take, and certainly that the testing has improved dramatically since 1983, which wasn't that long ago. But thank you very much for this presentation tonight. This was really superb. And I thank you all for your questions too. Those were awesome. And I know we could continue for hours, but we are going to conclude. And thank you, Dan Riconda, for moderating, and all of you all for being here tonight. You can see in the chat, there is a survey link. We hope that you'll fill this out. This really helps us plan future webinars. Our next topic will be January 11th on the topic of autism, and we hope you will join us then. So in the meantime, happy holidays, everyone. Thank you so much, Dr. Ballantyne, and we look forward to seeing you all in the new year.
Thank you, Susan. Thanks, Dan.
Thank you very much.